Welcome everyone, I'm Jeunesse Castonguay. For our last webinar of 2021, we're bringing back by popular demand the fabulous ultrasonography educator, Dr. Camilla Edwards. In today's practical small animal ultrasound webinar, she'll teach us systematic POCUS techniques for scanning the pancreas and adrenals, including imaging anatomical landmarks to find our targets. We'll see plenty of normal imaging and look at common pathologies to hone your diagnostic skills. Today's session is race approved, thanks to the Vet Show, so please do stay on for the full webinar to qualify for 1 CE CPD credit, which you'll be able to redeem via the Vet Show in the coming days. I'd like to thank all 4,800 doctors of veterinary medicine who registered for today's popular event. You're in for a highly practical session with Dr. Edwards, followed by live scanning. Our colleague Julian has brought his poodle called Mountain. Mountain will be scanned by your host, Dr. Aron Frankel, following the presentations. Let me introduce you. Dr. Aron Frankel is trained in emergency medicine in California. A passionate POCUS educator, Dr. Frankel has been using point-of-care ultrasound his entire career. He practices in a busy academic teaching hospital in Vancouver as an emergency physician and serves as chairman of our medical advisory board. Dr. Frankel, hello again and welcome.
Hi, Jeunesse. Thanks. It's good to be back for our last veterinary webinar of the year. And today's topic is a new one. We've covered in prior sessions cardiac scanning, pulmonary and thoracic space scanning, and also the AFAST. But there's another new area where ultrasound examinations can delineate morphological abnormalities. And with the improved resolution of recent ultrasound machines, the pancreas is one of those organs that's readily visible in normal small animals. And we'll see today how to incorporate that into your scanning workflows. Pancreatic disorders in dogs and cats are recognized with increasing frequency, and abdominal ultrasonography has assumed an important role in their diagnosis. We'll see that the normal pancreas is actually quite a small and inconspicuous organ of comparable echogenicity to the surrounding mesentery, and it could be difficult to identify. And that's why it's going to be really important to learn what the anatomic landmarks are and how to acquire a normal scan, which I hope to show later in a demonstration, though I admit I'm a bit nervous about moving forward with that. But we'll see that pancreatic disease and abnormalities are frequently investigated by means of ultrasound, and that can include pancreatitis, pseudocysts, abscesses, neoplastic lesions, and nodular hyperplasia, and also less frequently exocrine pancreatic insufficiency, pancreolithiasis, some congenital anomalies, and even pancreatic edema. And because the pancreas is such an important player and ultrasonographic findings in various pancreatic disorders overlap, those findings have to be judged, as we know, in light of the rest of the history and laboratory data. And sometimes you need cytology or histopathology to establish a definitive diagnosis. And yet, despite those limitations, ultrasound itself can not only be useful in diagnosing the pancreatic disease, but then also guiding aspirates and biopsies that can help identify the diagnosis and then monitor responses to treatment. Ultrasound has also become an important modality for imaging adrenal glands in small animals. This is another small organ that becomes of increasing importance in the endocrine workup in veterinary practice. And normal adrenal glands and structural abnormalities such as changes in size, shape, and echogenicity can be identified. And in the case of adrenal tumors, ultrasound can be an invaluable tool for identifying neoplastic masses with local and regional involvement, as well as even abdominal metastases. But like other endocrine indications, we have to correlate the clinical findings with results of hematologic, serum biochemical, and endocrine tests. But the ultrasound findings really make a substantial contribution to the diagnosis of adrenal diseases in small animals. So before we jump into the meat of today's topic, we want to throw a poll out there for all of you users who are now across the world from various levels of integrating ultrasound into your practice and seeing it in use. Please answer all of the above that may apply so that we can see that we're kind of all on the same page. And we want to see, where do you see the key advantages of using ultrasound for your veterinary medicine practice? Are you experiencing more rapid diagnosis or potentially improved diagnostic accuracy, getting to the diagnosis on the first visit, which in turn can sometimes help expedite the treatment plan so that things can get started earlier once you know the diagnosis you're addressing? Have you experienced or heard of stabilizing the patients in place without needing to transfer them to other radiologic suites or places in the same care facility? Have you used it to guide procedures or to monitor treatment efficacy with return patients after treatment plans have been initiated? Or have you experienced on the business side more revenue coming into your practice or experiencing increased referrals from other centers trying to get additional diagnostic imaging consolidated with other visits? We'll give you a second here before we close out the poll. Okay, so curious to see where everyone landed. And we can see it's really across the board. The biggest one seeing the more rapid diagnosis, which we all completely agree, and really trickling across with accuracy and then in treatment plan and some of the other advantages that we've seen over and over again in these webinars about how ultrasound can really assist in veterinary practice. And we can't think of anyone better to bring us today's topic than Dr. Camilla Edwards, who we're so happy to invite back. Dr. Camilla Edwards graduated from KVL in Denmark in 2006. She worked in general practice and emergency and critical care in the UK. She achieved a certificate in advanced veterinary practice in 2018 and started her company First Opinion Veterinary Ultrasound in 2018, where she scans for general practice in the UK, reviews ultrasound machines, teaches ultrasound, and runs a very active Facebook community with over 2,000 vets interested in ultrasound. Dr. Camilla, we're going to hand it back over to you here. Great.
Thanks very much, Oren. I'm really excited to be back and doing another webinar with Clarius. I'm really excited about this. And particularly this topic, it's a really tricky area to look for. So I'm always keen to help teach people how to find the pancreas and the adrenals. I must just mention conflict of interest declaration. I'm receiving an honorarium for this webinar, and I have a flat commission for ultrasound machines sold through my website, of which Clarius is one. So let's move on to scanning the pancreas and adrenals. So the first thing to think about is how to find the adrenals and the pancreas. We need to think about what the landmarks are, as Oren mentioned, so that we can consistently find these structures, because they are really tricky to see when they're normal. We're going to have a little look at the indications for scanning these organs and a little chat about signs of pathology to watch out for in the adrenals and the pancreas. We are assuming some knowledge, some basic knowledge about ultrasound machine setup and basic anatomy. This is tricky. This is not something to start off ultrasound scanning from day one. It's probably best to start on some larger organs before you attempt the adrenals and the pancreas. So I will start with the adrenals. The reason I've chosen this image is because it highlights the landmarks that we're interested in. So really the blood vessels, the large blood vessels of the abdomen that we're thinking about. The indications for scanning the adrenals include if we've got hyperadrenocorticism, and particularly to differentiate between pituitary dependent and adrenal dependent disease, it can be a useful tool with that. And if we suspect or have confirmed hypoadrenocorticism, it can help us confirm that diagnosis. And I include it as part of my normal full abdominal ultrasound examination. And that's because often with these patients where we've got hyperadrenocorticism or hypoadrenocorticism, we just have some signs that are not very specific, clinical signs that are not very specific, and often blood results that are not very specific. So what are you looking for? We can absolutely measure the length and the cranial pole thickness, but really what we're interested in is the caudal pole thickness. So for cats, that should lie around 0.3 to 0.45 centimetres. And in dogs, that does depend on the size of the dog. So if you're looking at a small dog under 10 kilos, you're looking at just over half centimetre or less. Whereas in a large dog, you could be getting up towards a centimetre. The left adrenal gland is peanut shaped, so it's got these two lobes. We've got what we'll call the cranial lobe and the caudal lobe, whereas the right is more L-shaped. Often it's easier to see this caudal lobe on the right-hand side, and the L shape disappears off in another direction. And with both, it can be useful to look for the phrenico-abdominal vein, which crosses over the adrenal glands. So we often see some artifacts that get in our way when we're looking for these organs. So refraction from the curved surface of the kidneys can cause a bit of a shadow over the adrenal gland area. Particularly gas from the colon and the duodenum can really get in the way, especially when we're trying to look for that right adrenal. We can also see artifacts when we see pathology. So, for example, if we see mineralization, we might see a hyperechoic area with an acoustic shadow beneath it. And that's definitely a sign of pathology in dogs, usually a sign of malignancy, whereas it's an incidental finding often in cats. So how do we scan these organs? We'll start with the left adrenal. And this is the sort of movement we're looking at with the ultrasound probe. So we're looking to follow the aorta and then fan at the point where we get to the left kidney. So here I am scanning my own dog. I'm going up into the dorsal area of the abdomen. Mid-abdomen I like to start because then I know I'm definitely behind the adrenal gland, and then I move the probe cranially. So here I've found the aorta on my screen. I try and get that into a longitudinal view. So this dark anechoic tube here is the aorta. And what I'm looking for is the curved renal artery, which comes off the aorta. I'm also looking for two dark dots cranial to that. That's the cranial mesenteric artery and the celiac artery. And it's in between these two dots and the renal artery that will find the left adrenal gland. So we fan in that area. So we've followed the aorta cranially. We're really looking for that aorta and the renal artery and those two dots, which are the cranial mesenteric artery and the celiac artery. So here's a drawing of that. So we've got the aorta in red, got the caudal vena cava in blue. We've got the left kidney over here and the right kidney over here. And so when we're looking for the left adrenal, we looked for this curved renal artery, and which comes from the aorta. And cranial to that, we've got the cranial mesenteric artery and the celiac artery. And it's in between those that we find the left adrenal. So again, just to demonstrate the image next to an ultrasound image. So again, here we've got the aorta demonstrated in red with the curved renal artery and the left adrenal just cranial to it. And we see that over here, we've got the aorta here, this anechoic tube with the renal artery curving off. And then cranial, here we've got the cranial mesenteric artery, and then we've got the left adrenal lying here. Actually, in Pippi, she has two left renal arteries, and that occurs in about 10% of dogs. So that's not that unusual to have two left renal arteries that are curved like this. But just cranial to them is this left adrenal gland. And again, in stills, we have this aorta with the renal artery curving off and the left adrenal gland just here. And we've got the cranial pole up this end and the caudal pole down here. And this is the same image, but just showing you where to measure. So you measure the thickness of this caudal pole. And as long as we've got the probe, because we've got it in a longitudinal view, we're pointing at cranial, caudal, then we can see that this is the cranial pole and this is the caudal pole. So in brief, to find the left adrenal, we follow the aorta cranial from the trifurcation or just cranial to it in longitudinal view. So the probe is in craniocaudal orientation. We move forward towards the head and we look for that hooked artery, which is the left renal artery. Cranial to that, we might see two anechoic circles, which are the cranial mesenteric artery and the celiac artery. And between the cranial mesenteric artery and the renal artery, that's the area we need to fan in. We don't necessarily need to have all those landmarks in one image. It's just the fact that we need to find those landmarks and then fan in that area. And that's the area that the left adrenal lies in. Moving on to the right adrenal. So again, here we're following the blood vessels, but now we've got the animal lying in left lateral recumbency. So we're scanning from the right-hand side of the body. And this means that we will have the caudal vena cava closer to us and the aorta slightly further away. And the landmarks that we're looking for here are where the aorta and the caudal vena cava diverge from each other. So where you can see caudally, they're very, very close to each other, and cranially, they start to move apart. And it's in that area where they start to move apart that you'll find the right adrenal. So again, we start with the probe in mid-abdomen. We move the probe cranially. So we have the probe dorsally on up towards the spine, looking for the long anechoic tubes, which we see here. Closest to us will be the caudal vena cava, and very close to that will be the aorta. So then we move cranially. You can see they're very close to each other currently, but as you move cranially, they start to move away from each other. Still, the closest the closest vessel we've got is the caudal vena cava, and that's where the right adrenal lies very close up against. But we move until we see that them diverge. So we can see the aorta down here and the caudal vena cava slightly higher up here. We can also just about make out the curved renal artery and the left adrenal from this side as well often. But what we're looking for is this torpedo shape or arrow-shaped organ, which lies just cranial to where the left adrenal is. So again, viewing that with an image next to it. So we've got the aorta here and the caudal vena cava closest to the probe. As I said, we can often see the renal artery and the left adrenal from this right-hand side. And it's important we don't mistake that left adrenal as being the right adrenal. We need to look further cranial, and often it lies about the level of the cranial mesenteric artery. So if we look at an ultrasound image, we've got the aorta coming down here and the caudal vena cava up here, and there's a bit of a gap here now, and we can see the renal, the right adrenal here lying close up against the caudal vena cava. So just within that red circle, we can see popping into view there is the right adrenal. And just to show you within the green circle, we can actually see the left adrenal popping into view occasionally, just cranial to that left renal artery.
With these tiny organs, it really emphasizes how much you need to practice, right? To even know that you're seeing the adrenal gland, right? It's a pretty challenging scan.
It is very challenging, and yeah, it's all about practice. It's about repeating it again and again, knowing your landmarks as well. That's the key, is really knowing your landmarks, knowing you're looking in the right area, and particularly, you know, if there is a big pathology, it usually stands out a bit more. So that's the good thing with ultrasound, is that it's often more obvious when it's gone wrong. This is a healthy dog. Again, so I've paused the images here, and we've got the caudal vena cava here and the aorta down here, and we've just frozen it where we've got the caudal pole of the right adrenal here. And again, just showing you how to measure. So you just measure the thickness of this caudal pole here. So the common pitfalls that we get with the adrenal glands are mistaking blood vessels for an adrenal gland. So they are quite dark and can appear quite anechoic. So it can be quite difficult to differentiate between those blood vessels around there and the adrenal glands. So one tip is to use colour Doppler if you're at all in doubt. Also, that can sometimes highlight the very tiny vessel, which is the phrenico-abdominal vein, which crosses over the center of the adrenal gland. So that can really highlight, if you think this is an adrenal gland and you get that tiny dot of flow going across it, that can really highlight that you've definitely got an adrenal gland. The other thing is mistaking the left adrenal gland for the right adrenal gland. So you need to make sure that you're actually far enough cranial, and that gets harder the larger dogs. Sometimes you need to go between the ribs to actually get far enough cranial to see the right adrenal gland. So in summary, with the right adrenal gland, we have them in left lateral recumbency. We find the caudal vena cava by scanning dorsally. You point towards the spine and fan in that area, mid-abdomen, to find the caudal vena cava. Then you follow that cranially, and you will see it disappear or move away from the aorta. And it's in that area that you need to start fanning. And you can fan all the way between the kidney, the aorta, and the caudal vena cava, and it'll be somewhere in that area. Usually it lies right up against the caudal vena cava, but sometimes it can be a little bit removed if there's, if you've got a fat animal, for example, there can be a bit of fat that pushes it away from the caudal vena cava. So when it comes to pathology, we're often looking at these dogs because we've either got a diagnosis of Cushing's or we're suspicious of Cushing's, so hypoadrenocorticism, and we want to differentiate whether we've got a pituitary dependent case, which is 80% of cases, in which case usually you'll have bilateral normal or slightly enlarged adrenal glands, like in this case over here. They just appear a bit plumper than normal, so just a little bit enlarged, but not usually drastically. They just have an appearance of being a bit rounder. And then you can have adrenal dependent cases, and that makes up about 20% of cases. And usually what you'll get in that case is a unilateral adrenomegaly. So you get quite a large adrenal gland, and the contralateral adrenal gland will atrophy. So it will be very small, really difficult to find. Similarly with hypoadrenocorticism, so Addison's disease, we're finding adrenal glands that are much smaller than normal, usually very thin. They appear very long and thin. You can also get a focal enlargement within an adrenal gland. And one thing that's particularly important to think about, if you have got a case where it appears that only one adrenal gland is effective and you're thinking about surgery to remove that adrenal gland, you really need to check for local vessel invasion. So typically the phrenico-abdominal vein or the caudal vena cava are invaded by tumours in the adrenal glands. Mineralization is something that we can see with pathology in the adrenals. In cats, that can be a normal finding in elderly cats, whereas in dogs, it's usually definitely a sign of malignancy. So this was a case just to demonstrate how large they can get. Before we were talking about structures that are under a centimetre, well under a centimetre, and this was a 5 centimetre adrenal gland. So pretty huge in this 6-year-old Rottweiler, and we could see that it had invaded into the blood vessel. We can see that we've put Doppler on, and it's the flow is just managing to squeeze past this invasion into the blood vessel. So that's key to know if you're thinking about approaching this surgically, because that makes surgery difficult, if not impossible, and really need to make some different decisions for those animals. Whereas an adrenalectomy is something that you can perform if there hasn't been any local vasculature invasion. So moving on to the pancreas, the other organ that is really notorious for being difficult to find in the abdomen. It's notorious for not being able to be found because it really looks like its background is isoechoic. So I think this picture demonstrates quite well why the pancreas is so difficult to find. It just looks like its background, so you have to work hard to spot it. So the indications for scanning the pancreas include cranial abdominal pain, vomiting, anorexia, lethargy, pretty non-specific signs really. But if we've got an inkling or a suspicion of pancreatitis, then we want to be scanning the pancreas. When we're thinking about what's normal, we'll think about the size, shape, and position. So in cats, the left limb is much easier to scan. It's much longer than the right limb, whereas in dogs, the right limb tends to be easier to scan. The body of the pancreas tends to be hard in all animals, mainly because we've got lots of gas in the stomach often, and that gets in the way of us viewing it. The margins, we expect those to be smooth. If they're becoming irregular, that might be a sign that there's pancreatitis going on. As I mentioned before, we expect it to be isoechoic. We expect it to be homogeneous. We will often see a hypoechoic or anechoic center, and that can really give us a clue as to where we are with the pancreas. In the left limb, this anechoic structure in the center will be the pancreatic duct, and that's often much more visible in cats. And in the right limb, what we're seeing is the pancreatico-duodenal vein. So we try to assess where the distribution of abnormalities. Often in pancreatitis, it's throughout the pancreas, so it's distributed throughout. But we try and view the pancreas in two planes, so trying to get a longitudinal view and a sagittal view if we can. And it's really, really important with the pancreas to register and really look at the mesentery or the fat that's surrounding the pancreas, because often that can be a big clue to a problem going on in the pancreas. So artifacts which will get in the way of the pancreas include gas in the gastrointestinal tract. That's going to be our major problem with the pancreas. So when we're looking at the right limb, the duodenum may contain gas, and when we're looking at the left limb or the body, then the stomach and the transverse colon will cause problems. So let's have a look at the anatomical landmarks that we need to think about. So here we've got the stomach, and then we've got the pyloroduodenal junction here, and moving into the duodenum. So the duodenum lies right next to the right limb of the pancreas. Over here, we've got the descending colon, transverse colon, ascending colon, and then we've got the spleen. So when we're thinking about the left limb, our landmarks really are the stomach, the spleen, and the transverse colon. So looking for the right limb of the pancreas, our number one landmark is the duodenum. So this little video is going to show us how to scan the right limb of the pancreas. We start up right in the corner, but where the ribs meet the lumbar musculature, and that's where we'll find the right kidney. So we're in left lateral recumbency, the head is away from us, head of Pippi. And then we just move the probe down the side of the dog. And we're looking for the duodenum. So that will be the first loop of small intestine that we come across there. So we'll see that at the top of our screen. It's really superficial, so it's really close to the probe. It's really straight, so we'll get a nice longitudinal view of the duodenum across the whole screen. When we're pointing the probe in a craniocaudal direction. And when we're looking like this through the duodenum, directly on the other side, sometimes just slightly dorsomedial, we'll see the right limb of the pancreas. But as you can see, there are bits of gas in the duodenum here, and that does tend to get in the way. So one of the things that we can do is rotate the probe to get a transverse view. That can help us to get a different angle on the pancreas and enable us to have a better look. So here I'm moving cranial to try and look for the pyloroduodenal junction down here, and that can help us look for the body of the pancreas. So here, rotating the probe round, we've got the duodenum here, and then we've got the triangular structure of the right limb of the pancreas on the side of the duodenum. So just this triangular shape. Often we can see a small anechoic dot in the center, and that will be our pancreatico-duodenal vein.
Is this also a scan you do routinely with all your abdominal ultrasounds? You mentioned that about the adrenals. You do the pancreas too, routinely?
Yeah, absolutely. Yeah, it's well worth having a look at the pancreas, because again, the clinical signs can be really vague with pancreatitis. So it's always worth just having a look for the pancreas for any signs of pathology. So this is a little bit more of a close-up where we've got the duodenum. We're just following it cranial to the pyloroduodenal junction around this corner, and we can just make out the hyperechoic edge of the pancreas. Again, we've got gas in the way, but this just on the other side is the pancreas. As we follow it, sometimes as we follow it around this corner, we can just get that hyperechoic edge of the pancreas, and that can help us to see it. So finding the right limb and the body of the pancreas, we'll start in left lateral recumbency. We'll find the caudal end of the right kidney, and we'll point the probe down towards the table. We need to slide the probe ventrally, and the most dorsal, superficial, straight loop of small intestine is the duodenum. We might come across the ascending colon first, so make sure that it's a loop of small intestine that you've got, and that it's right just on the other side of the abdominal wall. That will be your loop of duodenum. The right limb of the pancreas lies really close to the duodenum, so medial or dorsomedial to the duodenum. And the two things that can really help to get your eye in on it is to follow the duodenum cranially to the pyloroduodenal junction, where you might see the body of the pancreas and really see it turn that corner and towards the stomach and the portal vein, but also rotating the probe 90 degrees so you get a transverse view of the duodenum, and you'll get that nice triangular right limb of the pancreas structure on the side of the duodenum. Moving on to the left limb of the pancreas. So we're thinking about our landmarks again. The things that we're looking out for are the stomach, the transverse colon, and the spleen. So the left limb really follows the stomach up towards the splenic vessels, and on the other side we have the transverse colon. So here we've got Pippi in right lateral recumbency. So I like to find the colon just dorsal to the bladder. So we're looking for the descending colon first, and then we follow that cranially. So we've got colon here, and we attempt to follow that longitudinally and cranial until we get to the spleen, which we see here. I'm just adjusting my depth. I just want to look a little bit deeper. And then once we get to this, where we've followed the colon towards until the spleen, where it then turns off to become the transverse colon, we just need to rotate the probe a little until we get the stomach in the cranial part of the abdomen. So usually when we've got this, we're at about the level of the hilus of the spleen, and we'll see the splenic vein coming off, and which is moving down towards the portal vein. And it's in this area that we tend to find. So we look out for a slightly hypoechoic structure, just caudal to the stomach by the splenic vessels. So here we've got an image of trying to look for the left limb of the pancreas, where we've got the transverse colon coming in here. We've got the spleen close to the probe. We've got the stomach cranially, and we've got the splenic vein coming off here. And we can see just slightly hypoechoic area just next to the stomach, and that is the left limb of the spleen, the left limb of the pancreas, sorry. And it is very, very subtle, very, very difficult to see, particularly in a dog. In a cat, it stands out more, and particularly in older cats, it stands out even more because often they have a slightly dilated pancreatic duct. So just here in between the splenic vessel and the stomach, we could see that. So finding the left limb of the pancreas, we've got the animal in right lateral recumbency. We find the colon just dorsal to the bladder, and that's the descending colon at that point. We follow the colon cranially until it disappears off into the transverse colon, where it's heading off towards the right-hand side of the body. And this is what tends to be where we meet the spleen. And then we just do small rotations of the probe until we can get the stomach into view as well. So we should have the stomach cranial, the transverse colon caudal, and then the spleen up close to the probe. And it's in this location, we just do gentle fanning movements, and we try and keep all those landmarks in the same image while we're fanning, trying to follow the splenic vessels down to the portal vein. And this is where we'll see a slightly hypoechoic structure, which will be the left limb of the pancreas. So with pancreas pathology, the main thing that we are looking for, the most consistent finding, is hyperechoic peripancreatic structures. So basically a reaction in the fat around the pancreas. So we'll make the pancreas appear hypoechoic. So we can see that in this picture here. We've got the duodenum at the top here, and we've got the right limb of the pancreas here. But then it's really highlighted because the fat around it is quite bright. So it just makes the pancreas stand out much more. The other thing we can get is free fluid. So here we've got a transverse view of the duodenum, and we've got the triangular structure of the pancreas on the side here. And we can really see that anechoic tube, which is the pancreatico-duodenal vein running through. And then around the pancreas here, we've got a little bit of free fluid. So that's something else to look out for as well, which can be an indication of pancreatitis. We're also looking for increased thickness. So particularly in cats, the pancreas should be less than 1 centimetre thick. If it is increased from that, then we're concerned about pancreatitis. And we look at the margins as well. So looking for irregular margins would be an indicator of pathology. The great thing is that often the pancreas becomes more obvious with pathology. So if you can see the pancreas really, really clearly, then you've got to be quite concerned. So I included these studies because ultrasound is a great tool with diagnosing pancreatitis, but it is a tool in the armory. So we should include the serum pancreatic lipase immunoreactivity, so your CPLI or your FPLI, as well as including clinical signs and history. They should be all used in combination, and ultrasound's a really key part of that we should be using and including in our diagnosis of pancreatitis. We can't fully rely on our blood results, and we can't fully rely on ultrasound. It's a combination of all these things that we need to put together. So what are your take-home messages today? Well, the first thing is you really need to know your landmarks. So for the right limb of the pancreas, you're thinking duodenum. Left limb of the pancreas, we're thinking about the stomach, the transverse colon, and the spleen. And the body of the pancreas, we're thinking about the stomach and that pyloroduodenal junction. And if we can, see the portal vein. For your left adrenal, we're following that aorta until we see that renal artery curve off. We're seeing those two dots, the cranial mesenteric artery and the celiac artery. And it's in between the renal artery and the cranial mesenteric artery that we'll find the left adrenal. With the right adrenal, we're looking for the caudal vena cava, and where that goes away from the aorta, that's the area we'll find. But make sure you're cranial enough. And the changes that we're looking for, so in the pancreas, we're looking for hyperechoic fat. That's the major sign that we're looking for. We're looking for increased thickness, irregular margins, and free fluid as well. Adrenal glands, we're thinking about change in size in caudal pole thickness, but it's really important to compare how it is with the contralateral gland. Also, if we have got an enlarged adrenal gland and we're considering surgery, then it's really important to assess those local vessels for any signs of invasion. The main key to finding these organs is to practice finding the landmarks. Don't worry to begin with about actually seeing the organ. Just find those landmarks initially and celebrate winning, finding those landmarks initially. And once you've done that lots of times, then it will start to become clear. Thank you so much for listening to me this evening. Do get in touch with any questions, camilla@fovu.co.uk, and check out my website, fovu.co.uk. I can come out to scan if you're local to me. You can check out my reviews of ultrasound machines, including the Clarius. And I also run courses, and I've got a Facebook community where you're very welcome to join.
Thank you so much, Camilla. That was a great topic on, I will confess it is a challenging scan. And if you've been to some of these webinars before, you've seen me flounder a bit in trying to do scans that I was comfortable with on humans and not on animals, and doing it for the first time. And today we have mountain, and I feel like I'm a little intimidated. So Camilla, you're going to talk me through this. I'm going to try. I know we feel the ribs where they meet the dorsal musculature somewhere around here. We're going to put a little alcohol, right? Spread the fur. And then put some gel.
Plenty of gel, plenty of alcohol.
Plenty of gel, yep. And we're going to scan. Okay. And I'm going to try and find the duodenum. Is that the duodenum at the top of the screen?
Yeah, that's there at the top there.
Okay, or it was. Okay, let me see if I can get it back. There, duodenum.
Yeah,
right.
Beautiful.
And so I'm gonna, you said to follow it.
Follow it cranially, so towards the head. That's just in case you've got a short pancreas. Then
mounted. Okay.
You should see the pancreas just through the duodenum on the other
somewhere
side.
back here, right behind.
Exactly, lies up
to it. So
just parallel to the duodenum.
Yeah. Okay. I can't definitively say I see it. I mean, I do see this triangular structure right here.
Yeah, so if you rotate the probe 90 degrees, you'll get the transverse view of the duodenum, and that can make it a bit easier to see.
And do I want the indicator to the back then when I'm rotating it, or towards the...
I usually rotate it the other way. So
this way, so indicator down.
Ventrum, yeah.
Okay. Okay. So I'll try rotating it so we stay together here. So there, I'm going to rotate it slowly with 2 hands. Really make sure I keep that duodenum right in view. Okay. And so there's my duodenum, kind of still right in the middle of the screen. There's a bunch of gas in my way here. All right.
So and towards the right of that, you've got a little, on the other side of the duodenum there, you've got a little triangular structure.
Here? Or screen left? Screen left.
Screen right.
Screen right.
Yeah, just a hypoechoic area with a anechoic dot in the center.
If I bring the gain down, see it a bit better.
Yeah, that might highlight the anechoic dot a bit. You've got that it's very isoechoic, but slightly hypoechoic to the surrounding tissue. Triangular
this little thing, this little triangular thing right here. Whoa.
Exactly. That's the right limb of the pancreas.
Wow. Yeah. Well, good thing it's normal, right? So I can barely see it.
Exactly.
Okay, Mountain. That was great, Mountain. Thank you so much. I feel like a champ even for seeing it in view for a moment. Thank you so much for guiding me through that. Great. Well, we have great time left for Q&A. Let's hand it to Janez, and please use the Q&A on the bottom here, and I'll mediate that. We have so many questions. We're going to try and get to those. As you saw with Camilla's talk, we have ways that ultrasound can really help your veterinary practice, is that it can speed diagnosis on that first visit. If you're suspecting pancreatic or adrenal disease, you can image the organs right away, and then hopefully that will lead to better clinical results with more rapid patient treatment depending on what the condition is. And as you can see, even for a beginner like me on doing veterinary ultrasound, the app-based ultrasound is able to quickly adapt to the application. And you got to witness sort of a form of teleradiology where I could have my second opinion from Camilla on how to scan a pancreas. It's a pretty amazing, powerful tool. And ultimately, if this becomes integrated into your practice, ways that we see our clinicians who we work with finding that they're getting more word of mouth referrals, and clients are more satisfied with the care that they get. So thanks so much for all that amazing information. Again, please use the Q&A on the bottom of the Zoom screen, and we have some time to get to it. Janez, I'm going to hand it back over to you here.
Thanks, Dr. Frankel, and thank you, Dr. Edwards, for sharing best practices, and thank you, Julian and Mountain, for the lively demonstration. Before we begin our live Q&A, we have a question for you. This poll is an opportunity to learn more about Clarius wireless ultrasound for your veterinary practice. Let us know if we can provide further information about Clarius vet scanners. We do offer our scanners in over 90 countries, and so if you'd like to get a quote and learn about pricing, we can do that. If you'd like to speak to one of our experts about using ultrasound in your practice, we're happy to set up a call. You can book a Clarius demo live to be able to see it in action and ask questions. Or if you'd like to discuss features, we'd be happy to do that with you. And you can watch more tutorials as well. While you complete the poll, I'd like to introduce you all to Clarius HD Vet for the highest definition wireless ultrasound imaging to speed diagnosis for small, medium, and large animals. Our C7 microconvex vet scanner, which you saw today, is specifically designed for clear clinical imaging for small and medium animals like cats and dogs. We also have the C3 convex vet for larger animals and the L7 linear vet for equine MSK. Our family of vet scanners delivers several advantages. Clarius is unrivaled for high resolution imaging in a handheld wireless ultrasound with dedicated animal presets. It shows you the fine details you need to investigate an area of concern, perform a fast exam, and make a confident diagnosis on your patient's first visit to expedite the right treatment plan. Each scanner is designed with 8 beamformers that deliver the image quality and speed only found in traditional systems, but at a fraction of the cost. Artificial intelligence replaces complex knobs and buttons, making our scanners fast and easy to learn and use. Clarius is also wireless with zero footprint for high portability to scan animals where they are, from the vet clinic to their homes, and you get free movement with no wires getting in the way or startling the animals, also making it so much easier to clean and disinfect. Your Clarius scanner comes with a free ecosystem that includes free apps for your iOS and Android devices with free updates, free cloud storage to capture and manage your exams, and for unlimited users at no additional cost. Clarius Live delivers one-click telemedicine if you'd like to share live scanning with a colleague for a second opinion on some of the trickier scans you saw today. With increased ultrasound billings, you'll see a rapid return on your Clarius HD Vet scanner, which is ultra affordable. Thank you. We're just going to close up the poll. Thank you for participating. We will get back to you in the coming week. There's been just absolute amazing interest today. So now let's begin our live Q&A session. Please use the Q&A icon in the menu bar to ask your questions for Dr. Edwards. Because this is a common question, I do want to let everyone know that in the coming days, we'll send you an email with the recording for today's webinar, as well as a copy of the presentation and a link to the Vet Show to redeem your CE or CPD credit. I'd like to welcome back Dr. Frankel to moderate our Q&A with Dr. Camilla Edwards.
Great, yeah. Okay, so a lot of excellent questions. The first one is, where can I learn and what pathology looks like? More pathology slides in these applications.
Yeah, so I've got lots more pathology on my courses. Watching more webinars and joining courses is probably the way. Also, scanning yourself, scanning at every opportunity that you get, so that you'll get a good idea of what normal looks like, and then you'll see when those abnormal images come up.
Great. Specifically, I think this question for adrenals is, are there nearby lymph nodes that you might confuse with the adrenal glands? And if so, maybe how do you tell them apart?
Yeah, so it is really key to look at those landmarks. Those landmarks are really very specific to the adrenal glands. You may get renal lymph nodes in that region, and yes, lymph nodes look similar, but I would look out for those landmarks, and in particular that phrenico-abdominal vein, which crosses the center of the adrenal glands. You don't get anything like that in a lymph node, so that will really help you to differentiate any lymph nodes in that area. But it's not something that has ever been a issue that I've come across in any patients, because once you've got those landmarks, that is really the only structure that's there. So that's not a common problem.
Great. Maybe more when you're learning and trying to find it.
Yeah, I think, but yeah, again, it's about those landmarks. Find the landmarks and you'll be safe.
Yeah, great. Okay. This question, I think you kind of addressed this in the presentation. Maybe you can elaborate a little bit more. How do you interpret hyperechogenic pancreas, with or without? I think they meant steatitis or steatosis. How do you? Yeah, the hyperechogenic pancreas. What does that mean to you?
So yeah, that when you've got hyperechoic fat around the pancreas, and it basically causes like a mass effect. The pancreas stands out so clearly that it looks like a mass within the abdomen, because it's darker and the fat around it is so bright. And that is generally what we see with pancreatitis, and that is the most common thing we're going to find with the pancreas. And yes, we can consider neoplasia as well, and other types of tumour, but they may be more localised to a specific area, whereas pancreatitis tends to affect the whole pancreas. So often I'll spot the reactive fat before I am even looking for the pancreas. So just I'm looking at the liver and I'm looking at the stomach, and I'm just noticing that the fat around that area is bright. That makes me think, right, I need to go and check out my landmarks for my left limb of the pancreas to check out whether that looks like that is the cause of that reactive fat.
And that's also a sign of your expertise in the number of scans you've done where you know what normal looks like. So you're clearly cued that it's abnormal early on. So it really speaks to, especially in these more challenging scans, the more scans you do, the quicker you pick up on abnormalities.
Yeah. And really just practicing, even in those cases where you don't think they've got pancreatitis, practice those landmarks, take the time to do a full abdominal scan each time. That's the way you're going to improve at ultrasound.
There are several questions. I'll try and combine them together about, do you ever use dorsal recumbency? And if so, are you able to use the same landmarks?
So I don't use dorsal recumbency, and I think there's sort of a cultural divide. I think that often in the US, it seems that lots of people scan in dorsal recumbency, whereas in the UK and other countries, perhaps it's more common to scan in lateral. I've never learnt how to scan in dorsal. So the landmarks are definitely going to be similar. You can definitely look out for the same things, because we're talking landmarks which are tiny and extremely close. So definitely we can use the same landmarks. You can see that even when I'm looking for the right adrenal, I could see the left adrenal through. So even though it's a completely opposite side, I can still see that renal artery going around the left adrenal from the opposite side. So absolutely, in a dorsal recumbency, you're going to be able to see that too. So it's a cultural thing, and I think it's just what you're used to. We get a lot of clients who don't want their animals sedated if possible. So often that means lateral is easier to restrain the animal for the nurse in that position, and that's possibly why we've ended up doing more lateral scanning in this country.
Great. We are running out of time. One question I was actually curious about is, how do you know you have vessel invasion versus just compression of the vessels, say by an adrenal mass?
Yeah, so that you really want to get as many different angles on the ultrasound machine as you can. Using Doppler, you want to assess, from as many different angles. So you can very clearly see that the blood flow is squeezing past the mass, rather than just being compressed from the mass. But really that's assessing from as many different angles as you can, in longitudinal view as well, if possible. That will give you the best information on that.
Great. Well, I want to be respectful of everybody's time. Thanks so much, Camilla. If we didn't get to your questions, we will have someone from our team certainly follow up with you, right, Janez?
Absolutely.
Be able to follow up?
Yeah, we've had dozens of questions. If we didn't get to your question, we'll follow up by email in the coming week. And you'll also receive a copy of the slides and the webinar recording as soon as it's ready. So do keep an eye on your inbox. I'd like to conclude by thanking the star of our show, Dr. Camilla Edwards, and our furry supporting characters, Pippi and Mountain. Thank you to Dr. Frankel, and thank you to all of you for joining us here today. We look forward to seeing you again for a future webinar in the new year. Thank you all, and see you very soon.